Good afternoon to all and welcome. My name is Marwa Baluch and today I shall be discussing the dire issue of medical inequity and inequality within our North American healthcare system. Let's start off by understanding what medical inequity and inequality is. So medical inequity and inequality refers to the unequal and inequitable distribution of healthcare resources and access to healthcare services among different individuals or groups within a society. This can result in disparities in health outcomes and treatment options. In the context of the United States and Canada, there are several factors contributing to medical inequity and inequality, which will be discussed in this presentation. So we will be discussing racial disparities, women's reproductive rights, socioeconomic status, geographical disparities, connections to the media and to myself, as well as my campaign and solutions to this issue. Let's start off by understanding the racial disparities in access to healthcare. In both countries, marginalized racial and ethnic communities often face higher rates of chronic diseases and limited access to quality healthcare, resulting in poorer health outcomes compared to their white counterparts. So obviously, a difference in the level of treatment they are receiving, which is deeply rooted in bias and racist beliefs. Some specific biases and stigmas that are unfortunately very commonly believed in the medical world include the stereotype that Black people have a high pain tolerance in comparison to other races, making their very much valid pain be dismissed by the healthcare workers, even if they're unconscious of this bias. Unfortunately, a lot of East Asians are also discriminated against due to the ignorance associating them with the global spread of COVID-19. Again, workers might immediately dismiss their pain suspiciously, questioning their food diets and other such microaggressions. Racial disparities in the healthcare system can also manifest their way into clinical trials that have little to no representation of diverse races in their research, limiting the general application of findings, making it hard for doctors to find information that could be crucial to their patient who is of a marginalized race or ethnicity. Moving on to women's reproductive rights, particularly the impact of the landmark case Roe v. Wade. So legal protection is crucial for ensuring access to safe and legal abortion services, family planning, and reproductive health care, which were all protected rights when Roe v. Wade was implemented across all states. However, in recent years, banning preventive care and creating harsh restrictions disproportionately affect all women of all races, socioeconomic status, and living conditions, limiting their access to reproductive rights. These bans being held in place have led numerous women to the painful choice of attempting an unsafe abortion, potentially putting themselves at risk for numerous health concerns and increasing the rate of maternal and infant mortality. A study has also revealed that states that have put these restrictions in place apparently suffer from severe financial consequences, costing them and local economies almost $105 billion a year due to labor hours being reduced and an increase in time off between women aged 15 to 44 years old. Why, you might question? Well, it is simply because when women lack the healthcare that they deserve, they are forced to cut back on hours or have no choice but to leave the workforce entirely. Now, let's move on to the impact of socioeconomic status on health outcomes. Individuals with lower socioeconomic status often face barriers such as lack of health insurance and limited financial resources, leading to poor health outcomes compared to those with higher socioeconomic status. Some main issues that people with low socioeconomic status face include delaying the urgency for medical attention due to financial constraints or fear of high medical costs, which can lead to the underutilization of necessary preventive care and screenings that are crucial to further understand their health condition. People with lower socioeconomic status are also linked to having limited nutritious food access, prescription medication, or opportunities for physical activity. For example, insulin is very expensive in the United States, and if you know someone who suffers from diabetes, you might also be aware that it is something that they lack in their bodies, which they absolutely need and is crucial to maintaining their blood sugar levels. People with diabetes or anyone with a dangerous medical condition might save up for when they really need it. And this is not only highlighting the fact that so many helpless citizens are hanging on by a thread and barely making it, but also emphasizing the increasing rates of health issues. Individuals who suffer from low socioeconomic status and instability may also have constant stress and worry severely affecting their mental health, which then takes a toll on their physical health and just constantly being caught up in a cycle because so far the system has regretfully failed these people. Geographic disparities also play a role in the medical inequity and inequality within the healthcare system, especially in rural areas where limited healthcare infrastructure results in reduced access to services such as hospitals, clinics, and competent healthcare professionals. Living in such rural areas can lead to a delay in transportation to the nearest healthcare services, also increasing the risk for cases that need to be addressed immediately by urgency services. And as for services that are available in certain regions, they're most likely to not have efficient levels of preparedness for health emergencies, including pandemics and natural disasters. To further illustrate the impact of medical inequity, let's consider the movie Brain on Fire. It is a great example between medical inequity and inequality and the experiences of the main character, Susanna Cahalan, who suffers from a rare autoimmune disease. In the movie, Susanna initially struggles to receive an accurate diagnosis and appropriate treatment for her condition. This can be attributed to the lack of awareness and understanding of her symptoms by the medical professionals and teams she encounters. Susanna's privileged background and access to resources eventually enabled her to receive a correct diagnosis and access to specialized care. This storyline perfectly highlights the impact of medical inequity and inequality on individuals who may not have the same privileges and resources as Susanna. It also illustrates how systemic barriers such as limited access to healthcare facilities, poor health insurance coverage, and biases in medical practice can contribute to delayed or incorrect diagnosis, resulting in worse health outcomes. And on a personal note, nearly a year ago in March 2023, I experienced firsthand my own consequence of geographical disparities in healthcare. At Milton District Hospital, delays in essential care, improper administration of treatment, and lack of urgency were apparent, reflecting the challenges faced in quiet towns such as Milton. In order to tackle the issues being discussed, we must take the baby steps and really start from the foundation, which are healthcare professionals who make up our healthcare system. So what I decided to do for my campaign was create an outline for a certification program/course called the Ontario Caregivers for Equitable and Equal Healthcare, which will first be implemented in Ontario, then slowly progress to other provinces and states. The aim of the 6-day training program and course aims to equip Ontario healthcare professionals with the knowledge, skills, and empathy needed to address medical inequity and inequality in their practice. Participants will gain a deep understanding of social determinants of health, cultural competence, and strategies for providing the best healthcare to all. All legitimate and current licensed healthcare professionals that work or live in Ontario will have eligibility to sign up for the program and receive a certificate of training at the end of the course. So the daily course plan is as follows, which includes Day 1, understanding medical inequity, Day 2, cultural competence in healthcare, Day 3, health disparities across demographics, Day 4, in which strategies for equitable care are taught, Day 5, implementing change in practice, and Day 6 is like a final presentation and reflection lesson. Now that I have created my own potential step towards progress, here are some solutions that can be done in terms of the political scale, which include increase access to healthcare services in underserved communities, improve cultural competency and sensitivity of healthcare providers, implementing targeted interventions to address social factors of health such as poverty and education, expand health insurance coverage to ensure affordability for all individuals, enhance diversity and representation of underrepresented groups in the healthcare workforce by hiring from different backgrounds, developing and implementing policies to reduce healthcare disparities based on race, ethnicity, and socioeconomic status, increase funding for research on healthcare disparities and effective interventions, advocating and implementing policies that promote equitable distribution of healthcare, encouraging collaboration and coordination amongst healthcare organizations and such, implementing improvement of telehealth communication and digital health solutions to improve healthcare access in remote areas, improving data collection and reporting on healthcare disparities in order to inform others and spread education, and demanding equity and equality in the medical system by peacefully protesting. Thank you so much for your time. I do hope that you have the opportunity to learn more about this significant issue, and by visiting the QR code, which leads to a petition that I created, you could take your first step towards creating effective change in our medical system.